Welcome back to our channel. Today, we're diving into ankylosing spondylitis, or AS, a chronic inflammatory disease that primarily affects the axial skeleton, but can also involve other joints and even non-articular structures, as is about 3 times more common in males and typically begins between the ages of 20 and 30. There's a very strong genetic link. Roughly 90% of patients test positive for the HLA-B27 antigen. Outside the spine, about 30% of people with AS develop anterior uveitis, painful inflammation of the eye, and many also have other autoimmune conditions such as psoriasis or inflammatory bowel disease. Clinically, AS usually presents as a gradual onset of spinal pain, most often in the lower back, starting before age 45 and persisting for more than 3 months. Patients describe stiffness that's especially bad after periods of rest. Morning stiffness lasting over half an hour is common, but it surprisingly improves with activity. Fatigue is another hallmark. In addition to uveitis, you may see peripheral arthritis and enthesitis, which is inflammation where tendons and ligaments attach to bone. And because the spine can become brittle, there's a 4-fold higher risk of vertebral fractures. When someone comes in with chronic lower back pain, it's crucial to consider a broad differential. Spine-related causes include acute ligamentous injury and muscle strain, disc herniation with sciatica, degenerative joint disease, spondylolisthesis, epidural abscess or hematoma, spinal cord compression, tumor metastasis, spinal stenosis, transverse myelitis, vertebral osteomyelitis, discitis, and even spinal infarct. Renal causes like kidney stones or pyelonephritis can mimic back pain, as can intra-abdominal emergencies, abdominal aortic aneurysm, ulcer perforation, retrosacral appendicitis, large bowel obstruction, pancreatitis, or pelvic inflammatory disease. Don't forget rarer conditions such as retroperitoneal hemorrhage or masses, and even meningitis in severe cases. Diagnosing AS isn't straightforward. There's no single definitive test. ESR and CRP may be elevated but are non-specific. Plain X-rays of the lumbar spine and sacroiliac joints are key. Early on you'll see erosions and sclerosis, and over time the joint space may pseudo-widen and fuse, producing the classic bamboo spine. Unfortunately, these radiographic changes can lag clinical symptoms by up to a decade. You'll also run a CBC, a basic metabolic panel, and a urinalysis to exclude other causes, and consider HLA-B27 genetic testing, useful because of its high sensitivity, but not diagnostic by itself. While there's no cure for AS, treatment focuses on controlling pain and preserving function. First-line therapy is NSAIDs to relieve pain and stiffness. Sulfasalazine can help peripheral arthritis, though it doesn't benefit spinal involvement. Methotrexate and systemic steroids haven't shown clear efficacy for axial disease. For more severe cases, TNF-alpha inhibitors, etanercept, infliximab, golimumab or adalimumab offer rapid relief, though long-term outcome data are still emerging. Alongside medications, non-pharmacologic measures like regular exercise and posture training are vital. Finally, most diagnoses of AS are made in primary care or rheumatology clinics rather than the emergency department. If AS is first suspected in the ED, the patient is generally stable for discharge but needs close outpatient follow-up. Thanks for watching. Don't forget to like, subscribe, and hit the bell for more in-depth medical overviews.